over to Andrew Marshall so that he can present the second Spark grant under the Social Justice Committee.
Yeah, so really no introductions are required for our next speaker. So it's Mariama, who's well known to the residency and the office. And to contrast the great work that we just heard about, Mariama was actually doing stroke education work out in the community. And so it's one thing to really, get in there and teach physicians who have like a good kind of background in medical education, and kind of like good health literacy. And it's another thing to get out there and try to instruct high school students that have very low like medical literacy. And so she did a stroke education project that turned out quite well. And I'm just going to let her take it away.
Hi, everybody. Thank you so much for taking the time to here today. I'm just going to share my screen. Share screen. Share. Okay, let's see if that works when I press it. Can everyone see and hear today? Okay, so my project is patient education and community engagement around cerebral vascular accident in Roxbury and Dorchester. And I could probably ramble on the things that we've done for about an hour. So what I'm going to do today is to briefly review the information that I already presented in the midway presentation that is, let me see, wait, what's this doing this? That it mainly focuses on the content assessment, and then I will focus today on the information from the opinion survey. Okay, so the goal of this project is to increase community knowledge about signs of stroke and the timeline to respond to these signs and the actions that should be taken, as well as empower patients to be able to more easily engage with healthcare providers around stroke care and foster a positive relationship between Roxbury and Dorchester and the MGB community. So as Dr. Marshall mentioned, we developed patient education tools that were these interactive lessons that we delivered to high school students. We also did do some video work, and the video is not able to be assessed. So that's something that I won't really be going into today. But we assess the efficacy of the educational interventions. And we also have an opinion survey. The opinion survey, once again, is what I will be focusing on. If you recall, there is a strong mentoring component to this project. So we have Hammer faculty and residents, as well as Harvard Kennedy School and the Graduate School of Arts and Science economists, mentoring HMS, Harvard College, and Northeastern College students. And we're all working with Boston Public Schools to have this community partnership and develop this patient education. And there are different teams working on the different components. The main groups we're focusing on are students who received the classroom lesson and students who did not receive the classroom lesson, and comparing those groups to assess the efficacy of the lesson. And in the end, after the lesson, the lesson was ultimately delivered to all students so that they had equal learning opportunities after the experiment was done. The essential questions of the lesson that we went over are: what is a stroke? What are the signs and symptoms of stroke? Why it's important to get to the hospital as quickly as possible, and what are the stroke treatment options in their windows? And these are examples of some of the slides that were used that basically show that after 4 hours, TPA is no longer an option. After 24 hours, thrombectomy is no longer an option. The lesson was developed with very specific teaching pedagogy in mind for engagement. So We asked them about prior knowledge. We did Zoom polls, and we delivered the content through true or false. So there's very little lecture. I also had a lot of videos and illustrations for auditory and visual learners. And then for tactile learners, the students had these brain models, and I also used this brain model to deliver content. We went over case studies where we discussed patients who presented with different stroke symptoms after different periods of time that compared and contrasted the treatment options that were available to them. And this is an example of the video that we're working on to reinforce content. I'm not going to play that today. Okay. So once again, there's two different assessments. So there's the content assessment to assess how well people mastered the learning objectives, and then there's also the opinion survey that aims to gather information on community views and what the community needs. So this is very participant centered, where we're learning from them. So in terms of the data on how effective the lesson was, first, this is the econometrics analysis of the effectiveness of the lesson. So students in different groups came in with the same baseline knowledge. So this is just showing that there is no difference in the groups originally, but the students who received the lesson scored on average 10 points higher than the students who did not receive the lesson in the post-assessment. And 10 points is a big deal because the way the content assessment was designed, it's one objective per point. So basically, a 10-point difference is the difference between able to understand all the stroke symptoms or not being able to understand any of the stroke symptoms, and the difference between understanding that the time-sensitive nature of stroke treatment and not. And it could be the difference between understanding, what the stroke options are, what like the TPA and thrombectomy even are versus not. So 10 points is actually a huge difference. This is continuing to show that. And then students who received the lesson had individual knowledge growth of 12 points compared with students who did not. And that's very consistent with the point gain. So the students who did not receive the lesson had a 2-point increase in knowledge versus the 12 points. And some of the student feedback were, I liked how the lesson got us involved and engaged. I like how we got to hear from a doctor who happens to be Black and a woman. They liked the mini polls. They liked the videos and the visuals and the case studies. So those are things that information you all probably saw in the midway presentation. So that, once again, is just going over the effectiveness of the lesson design. And it's encouraging because that lets us know that we can continue to use this lesson for patient education, and that people should be learning the signs and symptoms of stroke and the time-sensitive nature and understanding their treatment options. So that this is something, the content from the lesson is something I would like to continue to deliver, not only to high school students, but to high-risk patients identified in the hospital, patients who are high risk of stroke, and also just community members at large, adults. So the opinion survey basically aims to assess attitudes and opinion towards healthcare, as well as their perception of stroke knowledge. So we actually had the respondents be skewed female, even though the class is 50-50, and that has to do with the response rates. So that's something in the future. I feel like I would get better response rates by doing all of the assessments, the pre and the post, just in the class, as opposed to virtually. We administered it, we let them take it virtually. So some of the students just didn't take it. And then we basically have the race of the students are, half of the students are Black, and also the ethnicity of the students, half of the students are Hispanic. A lot of the no answer students for race are Hispanic, and about half of the Black students are also Hispanic. So the first piece of information we've gotten from the opinion survey is participants valued familiarity with a hospital more than the distance of the hospital or reputation of specialists, even though all of those things had a positive effect on patients choosing to seek care at a hospital. So whether they personally have been to a hospital or their friend or family have been to the hospital, those are the most important things for them to decide whether or not they felt comfortable in a hospital. So as we see, strongly agree or agree is the majority here. I would go to a hospital that I've been to before, or I would go to a hospital that my friends and family have been to before. But in terms of like the going to a hospital that's closest, it's still 50% would prefer that, but that's less of a strong response. And then renowned for specialists, it's more than actually the distance, but it's not as strong of a response as having had personal familiarity with the hospital. So that's something interesting to keep in mind when we are hoping to make our healthcare accessible to all patients. A second bit of information on the opinion survey is about half of participants felt more comfortable in a hospital with Black or minority healthcare providers or patients. Recall that half of the participants are Black, but I have not yet correlated the individual responses. So technically, we don't know that the respondents who prefer providers of color are actually of color. And it's also very interesting that doctors and nurses solicited the same patient response. So the response is exactly the same for I would prefer a Black doctor as I would prefer a Black nurse. So we see here about half of the participants, a little over half, will feel more comfortable if they had a minority healthcare provider. And similarly, the same if they would go to a hospital where there are other Black patients, which is very interesting. And then you see here for if they would feel more comfortable if there are Black doctors. This is the same for Black nurses. So the third piece of information that we delved into in the opinion survey is about opinions on treatment by the healthcare system. So only 3% of respondents felt that they had been mistreated by the healthcare system because of their race, but 30% know someone who may have been. And this is interesting because age could be a factor in this, as the participants in the survey are high school students. So it could be a component of younger patients haven't been to the healthcare system as much, or also changes in the healthcare system being reflected over generations. So I'm very interested to administer the opinion survey to people of different ages. So as we see here, most people disagree or strongly disagree that they've been mistreated by a healthcare professional. These people who have no opinion probably haven't interacted very much. Well, is one hypothesis as to why they don't have an opinion as to yes or no. And then for someone that I know has been mistreated, there's this new 30% of people who know someone even though they haven't been mistreated. So delving into that in terms of like the mistreatment and kind of a lot of these questions are aimed at getting to the root of why Black patients preferentially kind of have a delayed presentation for many ailments, particularly stroke. So I did investigate, does the history of experimentation of Black patients or Tuskegee syphilis experiment affect their trust in the medical establishment? So about half of the participants said that negatively affected the history of experimentation of Black patients in the Tuskegee syphilis experiment negatively affected their trust in the medical establishment. Once again, it's not necessarily clear that the Black participants were the one who actually chose that. And some participants actually said there was a positive correlation. Don't know the demographics of those respondents. And also, I don't know their knowledge base. So this could be because, once again, they're high schoolers, they might not actually know what the Tuskegee experiment is, or they have another explanation as to why it was a positive effect. So as we see here, about like The majority are saying that the history of experimentation was negative or very negative. The history of the Tuskegee experiment, negative or very negative is here. Very positive effect is here. No effect is here. And so similarly, it's interesting when people are talking about their personal experiences seeking medical care, because about 50% of the participants actually had positive experiences seeking medical care. And then the majority of the rest of the other 50% just had no opinion. So presumably haven't not sought much medical care. But there was a difference of only 1% had a negative experience personally, but 11 had a negative experience through a loved one. And that is, once again, age may be a factor. So we see these are the personal experiences. The majority are positive, are very positive. There's a very small negative effect. And similar for the stories of friends or loved ones, but there is this increase in the negative effect. So another, I did also gather some hospital-specific data of comfort. So in this pilot, there is some suggestion that BWH and BMC may be seen as slightly more welcoming to Black patients when compared to MGH. All three were seen as more welcoming than Boston hospitals on average. And what was interesting about this is that despite in the subjective data and the free response data, participants did say, like, for example, they were happy to have a Black doctor come and speak with them, but their actual opinions on how welcoming the hospitals were not affected by the intervention. So this is strongly agree, Brigham and Women's is welcoming to Black patients. There's no disagree, there's just some indifferent. This is similar for BMC, strongly agree, BMC is welcoming. And then for Mass General, the strongly agree or agree is a little smaller, and there's this new disagree section. But for all hospitals, it is a smaller section agree or strongly agree that the hospitals are welcoming. And there's a larger section that says disagree. So that is the entirety of the opinion data on hospital utilization. And now I'm moving on to the opinion data on stroke knowledge. So based on, this is not necessarily objectively based on what knowledge they have. This is their perception of their knowledge. So participants believed that they had a greater ability to understand risk and benefits of different stroke treatment options. That was the most drastically improved ability after the perceived ability after the intervention. The ability to recognize signs and symptoms and the time-sensitive nature of stroke also increased. And what was interesting about this is that I do think that some of the a bit like the perceived, like basically participants' comfort with engaging in conversations around stroke care increased, possibly in the control group. And so that's something that I wanted to investigate as well in terms of cross-contamination, like students teaching their peers. I know cross-contamination when you're trying to do a neat experiment is not good, but from a community outreach standpoint, that would be great if people are peer teaching. And so that was one of my goals. So that's something I would like to continue to investigate in the future. So this is, the top are going to be the pre-surveys and the bottom is the post-survey. So we see ability to understand the risk and benefits of different stroke treatment. And then it's going to the majority. Oh, wait a minute. Can you all still hear? I got a weird alert on my phone. Okay. The majority understand the risk and benefits after the lesson was administered. This is ability to recognize signs of stroke before this many people would agree or strongly agree, and then recognizing signs of stroke after the intervention, more people strongly agreed. So it's about the same amount of people who could recognize it, but they just felt more confident in their abilities. And then understanding the time-sensitive nature of stroke, the majority said that they felt that they knew that before the lesson, but after the lesson, they were much more confident in the terms of understanding the time-sensitive nature of stroke. An interesting reflection I have on the opinion data is perceived versus actual knowledge. One thing I would like to do is correlate directly the opinion survey data with the content assessment to see if what was there a disparity in perceived versus actual knowledge anywhere and how we can target that. And another reflection I have on the opinion data is, how can we use what patients are telling us about their perceptions about, accessibility to healthcare and welcoming of different healthcare environments to foster patient empowerment and help them to feel that they can, access care at any hospital and engage with providers at any hospital and go to the closest hospital that's going to provide them with the appropriate level of care so that they can receive treatment in a timely fashion. So those are the main takeaways from the opinion data. Future directions for this project, many future directions. I would like to write up this pilot. One of the key next steps I would like to do is translate the lessons into Spanish and deliver them in Spanish, which Amelia Fano is working on. I would also like to improve the assessment responses, kind of modify just basically make it so that the data that we obtain has to be cleaned less. And also I think delivering the lessons in person will potentially make a big difference, but I also like that we have this information about it being delivered virtually, because a lot of stroke patients and patients that are at risk for stroke are not the most mobile and are largely homebound. So the fact that we could potentially give this information to them effectively remotely is something very good to know. We are hoping to add more covariates into the model in terms of the effectiveness of the lesson. And I mentioned investigating potential spillover, so peer teaching. Boston Public Schools would like to continue implementing these lessons next year. So I would like, that would be a new chapter of delivering the lessons in person and potentially having teachers from the emergency department as well as the neurology department. And we have been in contact with the neurology department at NGH. Dr. Nixie Mejia has done a lot of community outreach work as well, and she would be a potential partner in some of this work as well. So overall, I'm hoping that the stroke education could be delivered to patients at work for us, as well as just community members at large in a preventative fashion. So thank you all very much for listening, and thank you so much to the team that's worked so hard on this, as well as the Office of Ideas, who's provided a wonderful amount of support. Thank you. Any questions?
This is awesome, awesome work. And I think it really lays the groundwork for not only doing stroke education, but doing all sorts of education with our community and building lots of trust